So welcome, I'm Giovanni Zanaldo, the director for the Duke Center for International Global Studies. This is the second event, part of the Rethinking Diplomacy program, which is a new program that we just launched in last January, so a month ago. And the first talk was actually by Ambassador Pearson, who is sitting there, which was a sort of general introduction to the program. And now we are getting to the different these are sub-programs within the program that have to do with specific areas in which Duke is particularly strong. So one is health. So this is an event part of the health diplomacy. And then we have other sub-groups such as water diplomacy, food diplomacy, and et cetera, et cetera. So today, this event is also co-sponsored with the DGHI and also with the center that Gavin is director of. And the other thing about Daniel is that he's here as a fellow at the DGHI, and we are supporting his fellowship, and we are extremely grateful that he took the time to spend several months with us, and is already having an impact on campus with participating in different events and also conducting research, etc. He might tell us more about that.
I don't know how many of us who had the opportunity to be part of yesterday's distinguished lecture series. Paul Farmer spoke on global health equity, the future of global health equity. And I have a strong feeling that it actually set the agenda for this presentation today. I'm not a fan for hypotheses, but my thesis today is that the future of global health diplomacy lies, the global health equity lies in global health diplomacy, and how well or how unwell we rethink health diplomacy. We will look at this from this outline, a little bit of what health diplomacy is within the context of the broader term diplomacy, and very thankfully, His Excellency, the former ambassador, in the last series, explored the general concepts of diplomacy. So I'm not going to dwell so much on that, but to set the stage, we will give our own meaning of diplomacy and situate health diplomacy within that context. 2, there is a middle income gap that can arise when middle-income countries are transitioning. And 3, there is a case for domestic health financing to fund universal health coverage in all of low and middle-income countries. In 2014, the world faced this Ebola epidemic, particularly in West Africa, and then some parts of the Eastern Africa, Central Africa, the Congos. But particularly what happened in Sierra Leone, where China CDC had the resources and willingness to respond to this, and the US CDC also had experience and technical expertise. And they've been working together prior to the Ebola crisis. So what happened? The two countries forged a new type of collaboration in Sierra Leone, offering critical training and resources to Sierra Leone that helps in the containment of the Ebola epidemic. And that's a good news for diplomacy. The negotiation and ratification of the Framework Convention on Tobacco Control by WHO is another great example. This was a case where the WHO relied on evidence produced by both WHO and World Bank that showed the economic impact of tobacco on countries. For the high-income countries, yes, there was this fear, the panic. So the question here is it possible that we can break this cycle of panic and neglect and have a sustainable way of financing emergency preparedness in a way that benefits both the high and low and middle income countries? So will we ever break the vicious cycle of panic and neglect The second gap is also based on the forced transitions that are happening in middle-income countries, low and middle-income countries. We notice from the fourth D transition, as it's called at the CIPGH, the disease transitions, rise in non-communicable diseases, the demographic changes, the declining development assistance for health, and the increasing need for domestic resource mobilization. And I found this quote that I borrowed from Gavin's work, Gavin's slides. Very, very interesting. That it is no exaggeration to say that maintaining continued global health progress and certainly achieving an acceleration in progress will depend on how domestic and international health policymakers navigate this four critical transition. And I will add, negotiating and communicating. A lot of trade-off will happen, but give and take. We should be able to. So all middle-income countries are actually transiting, they are shifting disease burden and demography. How these shifts affect financing needs and mechanisms for financing. The argument here is that evidence-informed diplomacy will be needed to support transnational actors in developing and implementing a joined-up strategy. That is the main thesis here. This is a picture of the transition to NCDs that's underway in all 6 countries where CPI, the Center for Policy Impact in Global Health works. And I also acknowledge those Gavin and Campos who developed this slide. But I found it very useful to make a case. But this is what we've been battling with. HIV, tuberculosis, malaria, immunization, maternal and child health. So how, yes, the burden of these NCDs are increasing, but is it becoming our priorities globally? So why is it that chronic diseases, road traffic injuries, and social determinants of health have failed to get our attention and the funding that is commensurate to the disease burden? So this is a very fine case for diplomacy, for engagement among states and among between states, multilateral and bilateral actors. The gap 3 is about achieving universal health coverage. And that means there is financial protection, people are able to access health services of sufficient quality without any form of financial hardship. Now, this is what is happening across the globe. The low-income countries have huge external aids. The green ones are the external aids. The lower middle-income countries have some form of aids. But when you get to the upper middle income and high-income countries, the aid level, tapers off. But you will also notice that in lower middle-income countries and upper middle-income countries, there is also some form of increasing public spending on health, the blue bars. So generally, yes, there is an increase in public spending on health in middle-income countries. And then we ask our questions, what determines, what criteria do we use in allocating the health aids in spite of the transition? For multilateral funders, what still determines allocation mainly is this is Global Fund, this is Gavi, this is International Development Association, this is UNICEF, this is the United Nations Development Program. The economic indices, demographic indices are largely determining how we allocate, the donors allocate resources. Is it different when you see the bilateral funders? How does you say determine disease burden? Okay, they don't specify. Good governance index, human rights index. This is how you said determines what investments it makes in low and middle income countries in AIDS. Unfortunately, the external aid is declining, and we actually need common allocation criteria. Using evidence then to drive the investments that we make as countries and globally, and then sustaining the domestic resource mobilization, and finally, to develop and implement a common criteria for external aid. Thank you very much, ladies and gentlemen.